So today we are going to discuss a very interesting case which we recently did. So we had a 35-year-old male with history of recurrent acute pancreatitis with peripancreatic fluid collection. Along with this, the patient had developed a significant amount of pleural effusion, that is fluid in the chest. Now, in spite of removing the fluid in the chest, the patient had a recurrent, that is time and time again, collection of that fluid in the lungs, in the cavity around the lungs. So a chest tube was placed to drain that fluid, which showed continuously high outputs. Another point which made this case more complex was that the patient had an underlying congenital heart disease, a hole in the heart, which in medical terms is called as tetralogy of Fallot. Based on multiple discussions, we ended up doing a MRI of the abdomen and to see for any leak from the pancreas, which is going into the cavities around the lung. So on the MRI, we found that there was a leak from the pancreatic duct, which was communicating with the pleural cavity. We proceeded, after discussing the high-risk condition of the patient because of the underlying cardiac challenges with the cardiologist. We proceeded with a procedure known as ERCP and pancreatic duct stenting. Once we placed the stent, there was a dramatic improvement in the fluid output from the lung cavity, and eventually the chest tube was removed within the next 24 to 48 hours with zero fluid in the lung cavity. So this was a very interesting case that we stumbled upon, and with the help of our critical care team, the anesthesiologist and the cardiologist support, we were able to do a complex procedure of ERCP and pancreatic duct stenting in a case of congenital heart disease with a pancreaticopleural fistula, and with good results, and the patient walked out of the hospital comfortably.